This is part 3 of your endocrine lecture. We're starting with diabetes. Diabetes is a syndrome of glucose intolerance, diabetes mellitus. It causes chronic hyperglycemia and disturbance of metabolism. Now, you need to keep in mind normal pancreatic function. Now, the pancreas has several types of cells, and there's a table on page 459 that lists the different types of diabetes, but we're going to talk about some special ones in just a moment. The pancreas has alpha cells that produce glucagon, and glucagon is converted to glucose in the liver and raises your blood sugar. You have your beta cells that produce insulin, which insulin is necessary to transport glucose into the cells everywhere, but the brain, the kidneys, your eyelids, and red blood cells themselves. Glucose transport is facilitated with exercise into the skeletal muscle, so that means that when you exercise, you need less insulin to maintain normal blood sugar. And glucose or exercise also causes the secretion of amylin, which decreases your glucagon production and increases your feeling of satiety or fullness. You have delta cells that produce gastrin and somatostatin that metabolize carbohydrates, fat, and protein. And you have your pancreatic polypeptide cells that they're not really sure what they do, but they think they prevent the secretion of the exocrine pancreas and contraction of the gallbladder if the patient is hypoglycemic or after an increase in or after a high protein meal, so that your blood sugar stays a little bit more normal. Keep in mind that ketoacidosis occurs because of fat breakdown due to protein and fat metabolism. Now, as I mentioned, there are 3 types, there are multiple types, 3 main ones we're going to talk about. Type 1 used to be Roman numeral type 1, and before that it was called insulin-dependent diabetes mellitus. This results from a genetic environmental interaction in which the beta cells are destroyed. And usually you get symptoms when the beta cells are down to only 20%. 80% of the cells have been destroyed. Keep in mind that even though the beta cells are destroyed, the alpha cells are still producing glucagon. So your primary symptoms are the 3 polys: polyphagia, polyuria, and polydipsia. You're hyperglycemic. That the glucose, though, is not getting into the cells, so the cells keep sending off the message, feed me, I'm starving here. So you have polyphagia. You have breakdown of your proteins and your fats, so you get ketoacidosis and you get an acetone or fruity breath smell. The cells are not getting the energy they need, so you're fatigued. You'll have weight loss because you're burning up everything that you can to try and get the energy you need, but it's not getting into the cells. You're going to have polydipsia because the thirst center in the brain says, drink, we need to dilute this blood sugar that's circulating here, and that polydipsia, that increase that you're drinking, will cause polyuria, so you'll have an increase in urinary output. This is from the memory book, and it is showing, again, the 3 primary symptoms that are there and some of the other symptoms that occur with type 1 diabetes. It used to be juvenile onset diabetes also, prior to the insulin-dependent diabetes. Type 2 diabetes, Arabic number 2, used to be Roman numeral 2, and prior to that it was non-insulin dependent diabetes, and prior to that it was adult onset diabetes. They feel that this is due to an autosomal recessive gene. Again, it's a combination of genetics and environment. With type 2 diabetes, you have the beta cells becoming less responsive to the plasma glucose levels. The body's own cells become less receptive to the insulin that the body produces. So you don't get, no matter, you may have high insulin, but the cells aren't responding to it. So you might as well not have that insulin because it's not treating it the way it should be. Obesity is a major risk factor. It's usually the genetic environmental interaction. MODY is maturity onset diabetes in the young. So it's type 2 diabetes in the young. It's possibly an autosomal dominant factor, but it's also, keep in mind the fact that children are playing with computer games and sitting in front of video games and not necessarily out and about playing around, and their diets are not necessarily totally healthy. And so this is a variant of type 2 that is found in children. Symptoms for this is that they'll be overweight, have hyperlipidemia, itching, recurrent infections, visual changes, numbness and tingling, paresthesias. Risk factors for type 2 diabetes, about 50% of all patients with type 2 diabetes are undiagnosed for many years. So they have problems when they're diagnosed. But they tend to be overweight, tend to have a family history, tend to be female, again, it's an endocrine disorder, be Black, Hispanic, or Native American, or have metabolic syndrome. Now, there's a table on page 461 that lists the symptoms, including the rationale for the symptoms, so you need to look at that. And here again is somebody who has diabetes, and this big toe that you see down here means that diabetics oftentimes get gout. There's a table on page 464 that lists the oral hypoglycemics that are used to treat type 2 diabetes. And there's the figure on page 462 talks about the pathophysiology of diabetes. Gestational diabetes is due to increased demands of pregnancy. It results from insulin resistance due to the hormones that are released from the placenta. It usually occurs in the 24th to 28th week of gestation, and then resolves once the baby is delivered. But these women are prone to develop diabetes later on. Complications of diabetes, you've got your hypoglycemia, causes major risk for coma and death if it's untreated. Please remember that hypoglycemia kills brain cells because you do not need insulin to transport glucose into the brain. So if your blood sugar is only 60, that's all the brain is getting. And the brain, they believe, produces some of its own insulin. So that would lower that blood sugar even further. So keep that in mind. Diabetic ketoacidosis occurs only with type 1. This is due to the insufficient insulin production, the fact that they don't have any insulin production, and the loss of the beta cells. And it causes severe dehydration, hyperkalemia, and lactic acidosis, ketoacidosis, because they're going to have lots and lots of ketone bodies. HHNKS is hyperosmolar hyperglycemic non-ketotic syndrome. This occurs mainly with type 2. There are no ketone bodies formed with this one. That's why it's called non-ketotic, because the body still produces some insulin. Some textbooks call this HHS, hyperglycemic hyperosmolar state, but I prefer to put all the initials there because it tells you exactly what's going on with your patient. Hyperosmolar, you know they're dehydrated. Hyperglycemic, their blood sugars are elevated, usually in excess of 600. I've seen them as high as 1,800 for blood sugar with somebody with HHNKS. And then we'll have no ketone bodies. No ketone bodies. Their osmolarity will be greater than 320. You will find that a patient who has DKA will have a lower blood sugar than somebody who has HHNKS and still have problems. Because with HHNKS, we have insulin and are able to get glucose transported into the cells, where they cannot do that with diabetic ketoacidosis, so those patients get into trouble faster. There's a table on page 464 that compares DKA and HHS. This is a blood sugar mnemonic, hot and dry, sugar high, cold and clammy, you need some candy. You'll be talked to when you get into 224 about the fact that you need to give a simple as well as a complex carbohydrate, because otherwise that will raise your blood sugar fast and lower it even faster. Acronym for the simple symptoms that go along with hypoglycemia is tired. Again, looking at hypoglycemia, I may have mentioned that hypoglycemia kills brain cells, so it is very, very, very important that you understand the symptoms, recognize those symptoms, and are able to intervene appropriately. This is a flow chart looking at diabetic ketoacidosis. This is similar to the flow chart on page 465 in the textbook. Now, some other complications that occur are the Somogyi effect. Now, the Somogyi effect means that you're hypoglycemic at night, and then you have rebound hyperglycemia in the morning. So your patient will wake up in the morning hyperglycemic, but will tell you that they had terrible nightmares during the night, and they have this severe headache. That should cue you in that their blood sugar dropped during the night and are attempting to compensate, raise the blood sugar, and that gave you the hyperglycemia. Dawn phenomenon occurs because the insulin effects are waning off. And during the night, the body releases more growth hormone, and growth hormone raises your blood sugar. So kids really do grow at night, which was a statement made in an old Western with John Wayne that I watched. Dawn phenomenon means that they need their insulin readjusted. And here's a flow sheet of the Somogyi effect. And now we'll continue on with some more side effects. Diabetic neuropathy is mainly sensory symptoms rather than motor symptoms because of demyelinization of the nerves and probably vessel ischemia. So you're going to have numbness and tingling and paresthesias that occur in your nerves. And so you're going to have somebody who, if it's in their feet, feel like they're walking on 3-inch soles, even if they don't have shoes on. Think about when you're out and about on the beach, and you walk on the beach barefoot, get your feet wet, and the pad of sand that you walk on, somebody who has diabetic neuropathy feels like that all the time. So they do not notice when they have an abrasion or they step on a nail, a piece of glass, a stone. So diabetic people should always wear their shoes. Microvascular disease is due to thickening of the capillary basement membrane of the retina or the kidney. If it's the retina, that's due to retinal ischemia. That's influenced by growth hormone. Remember, that raises your blood sugar and your metabolic control. It will cause vein dilation and microaneurysm formation and hemorrhages in the eye. You can have retinal detachment, blurred vision, and cataract formation. So it's so important that if ever you see the sudden onset of flashing lights, you get to the eye doctor immediately. Do not pass go. Go directly to the ophthalmologist, because that could signify you've detached your retina, and if you don't have that taken care of within 24 hours, you could be permanently blind in that eye. So you need that taken care of. If it occurs in the kidney, you'll have diabetic nephropathy. That's due to the hyperglycemia, that increase in glomerular pressure causing damage to the basement membrane. So that allows protein to escape into the urine. The first sign that you have diabetic nephropathy is that you have more than a trace of protein in your urine. Even if you're on the Atkins diet, eating nothing but protein, you should only have a trace of protein in your urine. You have more than that, you have renal problems. If it persists, your life expectancy is less than 10 years. Macrovascular disease is due to atherosclerosis, and it tends to occur more often in your type 2 diabetic. They'll develop coronary artery disease, myocardial infarction, stroke, peripheral vascular disease. And keep in mind, they don't feel their feet well, so they risk trauma to those feet, ulcer formation, and diabetes is still the #1 cause of amputations in this country. Infections occur because of increased blood sugar content of the blood, and infections. Bacteria love sugar. It's also due to the fact that they have impaired visual ability because of the retinopathy. They may be hypoxic, have a decrease in blood supply because of the macrovascular problems, and impaired white blood cell function. So you have more infections there. There is a table on page 466 that lists the pathophysiology and the associated symptoms, so you need to look at that. And we're going to finish, because it makes a nice break here, part 3, and we will have a part 4 in just a second. Well, that is if you click on it.